Swayam Prabha. Digital India. Educated India.
Good morning, everyone. Welcome back. So today, first I'm going to talk about the COVID vaccine, the COVID situation and healthcare. I'm going to call it, using Charles Dickens' words, the tale of two cities. The reason I picked that kind of a parable is because we have completely did two opposite things. We all struggled throughout the globe how to handle the pandemic. We were learning. And so that was, if you want to call, one city. And then we kind of saved humankind to some extent by looking at the vaccine and using that to help us move forward. That I call as the second city. A vaccine that in the past has taken 10, 15 years to develop. We did it in 1 year. And so it's, as Charles Dickens, the author, would say, it was the best of times, it was the worst of times, kind of a thing. So both happened, which is why I chose that simile, if you want to call, the tale of two cities. Most of what I'm going to share with you, the data comes from the US, but it's applicable everywhere. The vaccine development, of course, is a global phenomenon. It was not just the US. So we'll finish that. And depending on time, then come back. We've not covered some of the slides from last evening. So we'll come back to that as time permits today. So let's start. So as Charles Dickens says, it was the best of times, it was the worst of times, it was the age of wisdom, it was the age of foolishness, it was the epoch of belief, it was the epoch of incredulity. So somehow he found out that humankind is going to go through this so many years after he wrote his fable. So I'm going to talk about the management of healthcare during COVID-19, the case study on resilience and innovation, and kind of point to us some critical questions that came out of that. So as service providers, as researchers, I think it'll behoove us if we don't ask those questions again. Then we will talk about the vaccine supply chain story. In supply chain management, you have two kind of chains. You have the development chain, right? So any product, any process, any service that you are developing has its own chain, technology transfer and all those kind of things. And then the supply chain, once it has been developed and deployed, then the whole supply chain that helps to manage. How do these two coexist? And how did they coexist so well in the vaccine supply chain that we were able to deliver the results in such a short amount of time? Is something for us to kind of pat ourselves on the back, at the same time understand what are some learnings that came out of that. So those are the two kind of things that I want to cover today. Of course, stop me anytime. If there's a question, if you have a clarification, this is us exchanging information. Remember, what did I say? Data rich, information poor. So you need to become more information rich as you finish this course. So this is what our learning outcomes I hope will happen. Understand the impact of COVID-19 on healthcare operations, supply chain management. Explore the supply and demand side uncertainties in the health supply chain during a pandemic. I'm going to introduce to you today another 2x2 matrix, and we'll use that to kind of understand supply and demand uncertainties. To examine the role of ventilator refurbishing. Yesterday we started talking about the reverse logistics and one of the R's was refurbishing. I'm going to take you through a case study that talked about a ventilator refurbishing and how it saved more lives. To analyze the structure and challenges of the vaccine supply chain during the pandemic. That will be the other learning outcome. So this is the data that comes from 2023, so far back into 4 years, from where we are, 4 to 5 years. So we've never had this kind of a pandemic, right? So at that point, the data said almost 754 million cases throughout the world, or 7.5 billion cases, confirmed cases. So the globe has never suffered something in our lifetime collectively with the pandemic. Most of the pandemics, most of the epidemics are geographical. You saw something happen in Asia, you saw something happening in Africa. Very geographical, though the spread would be pretty large, but still confined to a geography to which the rest of the world can kind of coordinate and help. But our case was each one had to defend ourselves of the globe. So there is no point in saying, did X country help the Y country? Because everybody was suffering in a similar way. And also, almost 6 million deaths in this case. So that's another huge part of that is human lives were lost. So what were some of the shortcomings and lessons? Always we like to look at it from a diagnostic perspective and say, did we learn something from it? Could we handle future pandemics slightly differently? So some of the shortcomings. So I'm going to take you to the US data for this, but I think the data speaks for itself. In the US, they talked about a national stockpile. Does the government maintain a centralized inventory? When I say national stockpile, that's a centralized inventory. So at that time when the COVID was breaking out in 2020, early part to later part of 2020, the CDC, in the US made an analysis and said, based on what we want to spread, we need actually 3.5 billion masks. 3.5 billion masks was what the prediction was. But centrally, they had only 12 million N95 masks at that point in time and 30 million surgical masks. So far, lower than what the expected number was. And imagine this was one country. Now take globally, how many manufacturers are there of N95 and masks? What was a very functional product? If the pandemic doesn't happen today, it becomes a very functional product. But once this happened, it behaved like a fashion product. It had that power of people needing it at that point in time for different reasons. And so that was the first shortfall. Just making up this shortfall was very difficult because lack of being able to procure or manufacture led to workplace conditions that increased fatalities from the pandemic. So this alone, people could not defend themselves in the initial stages as people were showing up for work. Along with that, we were also everybody in the world was going through the isolation part of it, right? So how do you isolate? How do you stay at home kind of a thing? For that, lack of supporting materials for testing, the syringes, the needles as examples, had impact of identifying infected population quarantine to properly dealing with quarantine. So two types of shortages. The mask was one shortage, which more like a prevention start, and the other one was the testing type of things. And of course, lack of available ventilators also led to very extreme consequences in many parts. I lost two of my closest relatives here in Bangalore, and one of them died because ventilator was not available at the right time at the peak of the pandemic. So all of us have some stories that we can relate to at that point in time. Challenges in effective distribution, access and provision of vaccines. Later on, that became an issue too. Vaccines were produced. Did they come at the right time? Were they distributed properly? I talked yesterday about countries like Ghana in the remote places where it was so difficult to distribute the vaccines. So all these are some of the shortcomings we are learning. We've come up with a lot of local solutions. People used all kinds of things to cover themselves. I know of a wine manufacturer in US that used their bottle filling facilities to fill the things that you want to use, the antiseptics that you want to use. And so people became very creative as to how they used what they have, every part of the world. But these are some of the shortcomings. So question later on I will post for us is, what role does government play in any of these? So now going back to the US, if you would stay with me for a second to get us a feel of why it affected US much more than other part of the world, and also it was a good blow to the US's ego in terms of how healthcare is delivered. Because of looking at this slide, you would see that Gartner, one of the largest consulting firms in the country, in the world, puts out an annual ranking of top supply chains in healthcare. And if you see this diagram, you would see that Johnson & Johnson, McKesson, Mercy, Medtronic, Boston Scientific, all these are top manufacturers in the world. And they were all ranked the top 25 in the United States at that time. And they're all headquartered in the United States. So United States, you could say, had the best of healthcare-based interventional companies' knowledge. So shame on us in that sense. Still, we couldn't collectively stop the bleeding in terms of saving. More deaths were happened in the U.S. per capita than any country. So no doubt about that. The other part that you want to see is the second diagram that I've put down. How does the supply chain happen in the U.S.? And we have similarities in India to this, but some uniqueness is there in this supply chain. If you look at that, you see 1, 2, 3, 4, 5, 6 major stakeholders in this particular supply chain. Of course, at one end is the patients, right? So that's the person that we are trying to cure. And then we have the providers, which are your healthcare, hospitals and tertiary units and whatnot that is trying to provide those services to the patients to get them better. Now, for the providers, such as hospital, clinics, and physicians, to do well, they need products. And the products come in, and of course, you have the payers who either could be government, could be insurance, who are individuals, whoever it is, the payers that is going to have access to both the providers as patients. Now, the providers are dealing with, in general, two types of people, and we have a distributor here. So distributors are the first level of, because of the lack of knowledge of all the parts and everything that the provider might have. Because the nurse might not know what all the manufacturers, all the products. Say, even an example is a wound care, right? Yes, a wound you need to have. They may not know everything. So they depend on a third party, such as a distributor, to provide them with the product and information. And the distributors would then deal with manufacturers that send the products to them. Sometimes providers can deal directly. I talked yesterday about the stent, about the valve that I have. These kind of devices, the hospitals love to deal with because they're pretty expensive, 100 to 200 times more expensive than other type of consumables. The IV fluid that you saw, those kind of things are less expensive than the specialized physician preferred items, as they called PPI. And so the hospitals might want to have some direct relationship with the manufacturers. In the US, however, let me finish one more and then I will stop here and take your questions. The US also has a third party, which is called the group purchasing organizations. There are variations of that in India, but this is pretty unique to the US, the third party. Because a lot of hospitals do not want to deal with contract, all the legal aspects of dealing with supply chain, right? So supply chain is not just, I come and buy something from you. I need to have a contract with you. I need to manage those contracts, and there may be thousands and thousands of contracts. So that would need an administrative wing in larger hospitals. So hospital systems would want to outsource that to somebody who takes care of not only the relationship with the distributor or with the manufacturer, but also the legal aspects of dealing with it. That's the group purchasing organization. Have in mind that organization as I go through the next few slides, because they played a role also in the... So any organization, sometimes what happens is the distributors themselves will have their own group purchasing organization. The group purchasing organization is more like a membership club kind of a thing. So everybody gets a membership into that, and you get a catalog of products that they deal with. Majority of the time, it is the catalog products that you order from. But sometimes they may say, a bedpan as an example. They could say, so the bedpans as an example, they would tell multiple hospitals, why don't you use this particular bedpan because we have a good rate from the manufacturer, the bigger discounts than somewhere else. So if a hospital were to say, I need a specific type of a bedpan, they could recommend, why not a standardized bedpan that we can get you at half the cost. So their idea is to reduce cost and increase availability. Those are the two things that group purchasing organization. They may not have their own inventory. They may still go to a distributor. They may still go to other warehouse service providers, which may have relationship with the manufacturer that sends to a warehouse. They hold it, and the distributor might bring it to the hospital. So that's a different. They don't physically deal with the products. They informationally deal with the product from a contract standpoint, pricing standpoint, availability standpoint.
My question is, then they can form a cartel and kind of monopolize the rates.
To some extent, you're right. They were doing it for the goodness of humankind is how we want to characterize them. Because healthcare is so different than other type of industries where you make money, this group purchasing, and they had, don't forget, they have government oversight. So they cannot operate in vacuum. So because of regulations and government oversight, an example would be for a life-saving drug, the government might say, I need X days of inventory, mandatory inventory. So the group purchasing organizations, as they write a contract with a manufacturer or with a pharmaceutical firm, cannot violate that rule. If that rule violation could help them to make more money or save more cost. So they can't do that. So there are regulations that control how goods are procured, how goods are moved. Example would be also cold storage. Certain things need cold storage at particular temperatures, and so they would have to comply with those kind of things. In other words, if they chose a supplier who's not complying with that, then they have to go to a different supplier. So those kind of regulations and oversight to some extent helps. The cartel nature comes in a very different way. In overzealous nature of getting cost reductions, sometimes what they do, which happened during COVID, is standardized products. Rather than having variety of products, standardize it to one or two for those kind of products which are functional in nature. And so suddenly the number of suppliers drops. And if one of the suppliers went under now because of COVID conditions, capacity became an issue. So it was not intended to create any havoc, but their good-natured way of doing business sometimes led to issues. So that's where I would characterize them as cartels, more in terms of standardization, not in terms of price collusion or things of that kind. Sometimes they may promote products. Don't get me wrong. They are not angels. All of them are not. They may have their own suppliers that they want to promote and things like that, but they have oversight. The healthcare oversight is there in many countries. So,
I don't think there's a mandate to buy from.
It is the convenience of buying from them. Most. Yeah, you're absolutely right. As a matter of fact, thank you for bringing that. In the United States, there has been Mayo as an example, Mayo Clinic. So Mayo Clinic is its own GPO. Because of the size of Mayo Clinic and the prevalence in only about 3 or 4 states, their mandate is they manage the entire supply chain internally. So Mayo Clinic has its own GPO, kind of internal unit that deals with contracts, that deals with things like that. Second example, to go back to Professor's point, is some states now have said, thanks to the word cartel that you used, I don't want to use it in a wrong way, but that mentality of groupism and conducting business that way, some states have said, mandated, Florida is one of the states that said state would have its own GPO. It's a state-run GPO. All the hospitals have to go through them. So there are movements which non-profit kind of GPOs have come on board to help, either hospitals themselves, because we look at companies like in my state of Arizona, we have Banner Medical System, which has 27 hospitals across 3 states. So they have their own internal GPO. The size kind of provides that kind of luxury to you to manage your own GPO. So the checks and balances comes that way. So another hospital system in my state, if it is not happy with its GPO, it can come and talk to even its competitor and say, can I use your GPO strength for me to purchase things? Still, the decision is the hospitals, what to purchase, when to purchase, how much to purchase. Those decisions are not taken away from the hospital. It is the physicality of maintaining the inventory along the supply chain and the legality of frameworks of writing contracts and managing. That's the headache some hospitals don't want to have. Very good. Yeah. The research problem would be, would GPOs work in the Indian context?
Also, CPP is...
Yeah.
GEM is a part of that, I believe. GEM, it's mandated that for government, but all the PSUs who are working in any fields, they have to first, for all general items, they have to go to GEM. If it is not available, they have to get a non-available certificate before they are going to other.
This is the government hospital?
It's anything, any government organization, for that matter, they have to go to the GEM.
Otherwise, then it's like this to me. It's but how far they are successful. That's a good point. What is fun is a success. You're back over. Second, the problem.
Yeah. More from a supply chain standpoint, what role does the GPO play in non-critical items? I have to be very careful when I say that. In non-critical items, to reduce cost by standardization. Non-critical items. Critical items, physician-preferred items, they fall into. So it's any procurement, if you think of it, is a categorization. That's how people manage procurement. You start categorizing. One way of categorizing would be the A, B, C products, right? The products that are only 10% of the time used, but have 90% cost or value to it. Next would be B, which is 40% of the items by volume, but probably about 50 to 60% of the cost. And then the C items, almost 80% of the items, but from a cost perspective is only 10 or 20% of the value. So you categorize based on it, which also tells you the one that falls into a high cost means it may be more critical or it may have some functionalities that are different than the C items. So categorization is where procurement starts to understand itself, to write the contract itself. Inventory policies itself. For most of the B and C items, you would say, once in a while I want to go check that inventory and place an order. Whereas A items, every item that's consumed, you want to question. Should I manage the inventory now? Should I place an order because they are so critical? So more is going into your A items than into your B and C. Now, same thing is who is doing that? You as a hospital system can do it yourself, but it's a burden on you, burden on information systems. So that is why you're saying, can I outsource it to somebody else to do it? They could be sitting inside the hospital. Some of these GPUs have members sitting within the hospital, glued into the hospital's information system, looking at electronic health records, and thereby. So it is not just hands-off kind of relationship with GPOs. But as the gentleman rightly said, if it is such a non-essential or kind of an item that first you want to go to somewhere else, that's availability, you can do that too.
Sir, is it so that the type of business we are in as an organization, it also depends. Like I have one example of Ineto. It's a US based firm. They have their manufacturing facility here in Bangalore, and they only focus on research. They are developing on the second version of that. But the manufacturing part of it has been given to Centum Electronics. So they are more focused on their core things. They are not involving in this. Similar hospital facilities are in healthcare services. They are providing the healthcare as a product. They are not managing that. So that is their core focus. So is it so, like, am I understanding it correct? This is also the case of existence of these GPOs and all.
Very, very true. Let me also talk about in the same thing, like I talked about my situation and the valve that went in. My doctor, the cardiac surgeon, owns part of that particular company. He signed a non-disclosure and all those kind of things. Because over a period of time doing this operation, he has understood how the product should be developed. So he's also worked with the research and development wing of a company that does this for themselves. Of course, when it comes to manufacture, you're right, then it is outsourced to a third party that is manufactured. So hospitals can play a role in technology or medicinal kind of development. They may own it, they may not own it. Boston Scientific has even hospitals that owns some of this part of it. So it's not a clear-cut answer of here is where I'm going to give it off, but it's be careful with what the gentleman said. There is collusion should not happen. Pricing should not be dictated by that, and so on and so forth. So in my case, Mayo gave me a different option. So there were options available. So the pricing is not dictated by one particular hospital or one particular manufacturer. That's the only difference I'll try to tell you. Oops. What do I do? Decline?
So in this pyramid,
More decline.
you mentioned these Cleveland Clinic, Mayo Clinic, these are all understood as GPOs in this pyramid. And why is Mayo Clinic separately below in the pyramid?
Okay, so the way that pyramid should be understood as follows. It's a ranking. Mayo Clinic, Intermountain Healthcare, Cardinal Health, and Masters. These are all healthcare firms that consistently win on the top. So at one point in time, Gartner said, you guys should not be competing because every year you compete, you'll be the top. So they put them as the master Jedi kind of thing. So they are always at the bottom. They are the best of the best, and the rest can compete. So they look at the rest as, okay, you did X this year. Next year, you became better in doing that X. So you have improved. Once in a while, they would talk about Mayo and otherwise. So that's how you take it. The bottom of the pyramid are the best of the best. Cardinal Health is more hospital systems. Mayo is more hospital. So those are all hospital systems at the bottom of the pyramid. Thank you.
So in terms of these GPOs, in our states, we have the CMS approved firm. CMS, we call it.
Sure.
It's a central thing. The state used to regulate it. And there are cappings on the rates on which the drugs and consumables are being supplied.
Sure.
Now, sir, for the problem don't come up to district level. But for the peripheral hospitals, when they put any order through CMS portal, now the company says that as the rates are too low, they operate in bulks. They can supply in bulk. But for the peripheral hospital, they cannot purchase it in bulk. So this place the order as per their requirement. But many often that order get cancelled. So this causing a bottleneck. So are there any study from US or from Indian perspective how in periphery these things have been controlled or tackled?
It's a good question. I don't know on top of my head of any study. We could find out and let them know. However, I'm surprised also because of, if the healthcare is not delivered because of that, the outcomes are not there. Because is there a shortage of medicine because the others are not supplying? That's what.
District supply. So district used to take in a bulk and they used to supply to us. But there is no freedom for our side to place any order in a small quantity, in a limited quantity. So we have to depend on district. Sometimes there are stockouts, and when district gives supply, then only you can use. This things goes on.
Yeah.
Exactly. It's like
Government that need to go through the financial norms, procedures, maintaining everything. So we cannot go outside CMS. So there is no liberty that we go to some other big cities nearby and purchase it in small amount. Until now, there are some approval from higher authorities. Like in COVID, there we got some approval. DM has given us some approval like that. But in general situation, we had to rely on our central supply system.
I'm with you on that. I'm just trying to understand. I don't want to, we can even take offline and talk about this. We happen to have this in Ghana also. In situations where mostly government-based healthcare happens and where there is primary and tertiary care hospitals, then the system that is set up as to how to order could become an issue. That's what you're saying, because of order quantities and things of that kind. So, is there escalation if there is shortages, is the question that I have. If so, what happens to those escalation? Ghanaian system at one point in time became so acutely shortage that it led to malaria-lead medicine and non-availability, leading to deaths, that day-to-day escalation towards the Ministry of Health had to happen. So things like the visibility of the lack of doing something and its impact on healthcare, is that escalated, then what happens in a government-led healthcare? So I don't know the answer to that question, but at least, are there visibility issues?
The other aspect is that, when we talk about GPOs or structures like that, especially for the small orders, you just see that GPO or any centralized facility, when they will aggregate the smaller orders across hospitals, then it is actually easier to buy.
That's true.
Okay, number one. Number two, the negotiation powers for GPOs increased as compared to a standalone hospital, to buy the same order. So if you see that arrangement, so from that perspective, so the centralized purchasing or structures like GPOs are very beneficial. Okay.
I think a very good point.
like slam pricing that
Yes.
we're buying up a certain quantity.
Yeah. This is very much practiced in Indian manufacturing auto sector. Auto manufacturers, they are buying steel not for themselves. They are pooling the demand across all their tier 1, tier 2, tier 3 suppliers. They buy for them, because if each tier 1, tier 2 supplier will order for themselves, it would be costly affair. So the OEMs, the assemblers, auto giants, they are buying on behalf of them, and then they are sending to all tier 1, tier 3. The same concept, centralizing it, especially when you have small orders, it is actually more beneficial to go through this GPOs or centralized structure.
But I am with you. I empathize with you, because it's the power of who is going to do it. The example professor is giving is the power still is with the auto manufacturers, and they can demand that the pooling happen and get a better price and give it. In this case, it should be at a state level, or whoever has the power to do this could help the smaller ones to pool their demand together. Information systems could be another way of getting this information to the pooling level.
So one other benefit which we are practically having it, there are restrictions that for particular supplier or OEM, they cannot supply directly to particular regions. So for our organization, we are in Central Procurement Unit. We are coordinating from Bangalore, and we have 9 locations in MENA region: UAE, Qatar, Kuwait, Oman, Jordan, Lebanon, Iraq, Syria. So the other regions, Syria and Iraq, the payments also we cannot directly transfer from there into some supplier in US or Australia. The transaction also is not happening there. Even the material flow is not there. So what we do, we have headquartered in UAE. So UAE, we will take all the materials there, and then we intercompany stock transfer we will do at our logistics cost. So that is also a benefit which like financial sanctions are there, but then medical equipments will be needed. So that is
I think the two part to what we will just finish with that. One is the part where the pricing happens and the quantity, that's what you're talking. Second is the physical distribution of products, which is again another issue as to which warehouse is going to hold and who is going to distribute it. So those are structural level questions. Unless a structural level answer happens, it's going to be difficult to deal at the individual level. It may be difficult. So, okay, let's keep going. When you talk about healthcare, why did this happen in the US? We talk about the centralized aspect, and here is one other perfect storm. Remember the providers of the care. So from their perspective, US was going through a lot of mergers and acquisitions. Like any other business, healthcare is also to some extent a business. So hospitals buying fellow hospitals, which is to some extent happening in this part of the world also. So, and leveraged buyouts always talk about how do I improve profitability. And one way is if you reduce the number of beds so that the number of the bed-based profitability goes up. So mergers and acquisitions over the period of time reduce the number of beds from 1.5 million to 900,000 beds, which had a big impact because now suddenly during COVID, you had to isolate patients, you have to need beds, and that became an issue. Focus on cost, lean, GIT, low unit of measure. Hospitals went through this for some times. They were also looking at how can you bring items at the right time? How do you standardize items so that you don't have too much variety and the cost can come down? Because of number one, number three happened. As the beds reduced, more people will move to outpatient. So constantly people are thinking about, should this be inpatient? Should this be outpatient? We started off with the hospital system and Mary's problems. It's an inpatient problem, which is why you need to have the IV and everything in the way it is. So the outpatient settings, COVID needed inpatient settings, so it had an issue. Supply chain for a large companies in healthcare, people started thinking based on the GPOs as a revenue center. If you think about it, supply chain is a cost center. It manages the costs. So the moment you think about revenue center, that is a supply chain center should also be producing profit, then obviously the mentality would be different in terms of how do I reduce not only cost, but how can I eliminate anything so that I can show more profit. So community benefit not equal to public health benefit. So people get mistaken between community hospitals and what they do versus what COVID did was public health had to be looked at, which means massive numbers. Community hospitals by very definition are smaller settings. And you said rightly, because of that you now have smaller orders that go out and all, but COVID was very different public health setting. So that meant, so it was a good thing when healthcare is delivered in community settings, but it was inadequate when it came to COVID. The outsource risk of GP to GPOs and distributors, because they had a lot of sole sourcing kind of a thing to reduce cost, which created issues in terms of capacity availability, especially the masks and surgical gloves and things of that kind. So that's just from the provider standpoint what happened. Now, as you go through the supply chain, it was a perfect storm also for suppliers and manufacturers because they were outsourcing a lot of components to a different part of the world. Many of them, like any other business, had China as a primary source of developing products and sending them. So anytime you go outside of your geography, your supply chain is lengthened, right? It takes time to get things into your supply chain. Lengthened response time. So that happened. Continual move to lower cost suppliers. So when you're thinking about only low cost suppliers, that has its charm and that has its limitations. If a low cost supplier might not have the luxury to expand quickly, they are operating under a particular tight kind of spectrum which gives them that ability to provide you at the low cost. So flexibility, somebody brought up, is not a trait with a low cost supplier. And so what we needed was flexibility in order, so that had an impact. Lack of knowledge, I think you brought up about mapping. Now, because of COVID going to 2 or 3 layers, that's an outcome of COVID. If at all anything happened across the globe, is every supply chain, people are now asking, how deep is my supply chain is the first question. How much of the depth should I know is the second question. If you take an automotive manufacturer, they say they are 7 deep, is the kind of question. 7 layers of suppliers, as Professor said, all the way to the Mother Earth. How much of this should I know? Sometimes you need to know the 7th layer if you are dealing with rare earth material and it affects your capacity to produce certain components that are needed for manufacture. So that whole thing about lack of knowledge of risk related to tier 2 and tier 3 suppliers. Because normally what we do in supply chain, our next level of suppliers is the one that we feel comfortable dealing with, and we let them deal with the layers after that. But the risk, lower tier sometimes affects the upper tier suppliers. So that lack of knowledge is also created along with the sole and single sourcing. So that's for the perfect storm for suppliers and manufacturers in healthcare. The intermediaries, such as the group purchasing, even they had issues. So they were pushing their members to standardize, reduce the supplier base, which blew up in the face of COVID. They were accountable to members to reduce costs. The hospitals themselves were saying, like you were talking about, we'll increase the volume, get us a better price, or reduce the cost, even at the current volume. So the flexibility was lost for the GPOs to go to and develop suppliers. They were constantly consolidating suppliers. When I used to work in Lucas TVS 40 years ago, my role was also called supplier development. It's a very interesting word if you think about it. Why should a company such as Lucas TVS, which is a powerhouse, help in developing suppliers rather than controlling suppliers or managing suppliers? Because if the supply chain ecosystem is healthy, could your health. If you look at Toyota as an example, the whole thing called Kiretsu, which means they have their own supplier base. Not only they help them technically to be better, they also help them financially by owning banks Toyota owns, which gives a loan at a reasonable interest rate to your supplier. So your supplier has to be financially solvent as much as technically good. So that kind of a mentality is part of developing suppliers. And the other thing I did when I was at that time was our own employees would quit and become suppliers because they became very good at something that's a nice way of developing suppliers because you trust them more. They were part of you who have now become suppliers. So supplier development is a very critical part that we missed along the way as the globe became more competitive and what we wanted to do. And to some extent that we saw that happen when we went back to needing them a lot during COVID. So same thing about distributors, and then regulations also had all kinds of impacts as to things, how fast you can change or you cannot change. So that's the intermediaries. Government. So we can't leave them out of the picture. They had the perfect storm in COVID because many of these mandates were underfunded. Because people simply, no country was prepared for a pandemic. That's the bottom line. Of this level, again, regional outbreaks, things like that, people deal. But a massive one of this that needs a central government intervention a lot has been challenging. Underfunded, undermanaged, outsource again, if the countries are also depending on outside. We talked about Ghana as an example where I said 80% of the drugs are imported. So they are dependent on other countries, which in this case, it was perfect storm. No country was able to help another country. So outsourced to commercial distributors without accountability. During COVID, one of the roles I played, a lot of us played in the US, is a call center operator. I was a call center operator for a government-based logistics distribution hub. Our role was to see which distributor had what in terms of masks and those kind of gloves and things like that. Who owns the trucks that has the capacity? Which hospitals were needed? So we were like sitting in front of a screen, trying to divert trucks, pick up products, deliver to the hospitals. And we were given regional kind of healthcare areas to manage. So some of us volunteered with that work. And we found out very soon that government doesn't truly have the accountability to tell this truck to go there because they all have their own things. So we had to go through all types of non-profit type of organizations to help us do that. Again, lack of knowledge of tier 2 and 3, inadequate information systems, which came out a lot. People thought they had X amount of masks where it was not. So that type of issue also became the forefront. So public health understanding came to a front page. It was always in the back page in any journal. And so that's what happened. So some of the key takeaways. It's always nice. You can do what they call us look through the mirror afterwards and see what has happened. And but I think it's important to have some key takeaways. So the inaction or lack of untimely action of a centralized planning and response in US, I want to be very careful when I say this. I don't have the first-hand knowledge of what happened in India. So in the US, I say fail to manage the capacity leading to shortages with extreme outcomes. So that is very clearly documented in the US. Has anything changed? I don't think so. Initially, people rise to the occasion and then we go back to our old ways of doing things when things settle down, unfortunately. Market solutions. So if you talk about the US, you say, oh, the best country in the world for market solutions. Market will respond. Market knows what to do. Government should not interfere. You hear these things a lot. But market solutions, which is private service providers, fail to make a dent due to past experiences because they never trust the government. So anything government asked, even though I'm going to tell later on, the government brought out a war act and asked Tesla and General Motors to produce ventilators. The results were mixed, right? So it's not like even if they provide the provision, things happen. But with the vaccine, it was very different because upfront loans and upfront guarantees on finances was humongous. Everybody talks about Pfizer. Oh, what a great job. $10 billion advanced contract was signed with Pfizer. $10 billion worth of contract, which was released in stages. So money as a guarantee moves a lot of things. Private concerns alone does not. The hyper-globalized nature of healthcare supply chains, when subjected to global upheavals and other vulnerabilities due to national and local politics, will break under undue strain, which is my statement. So we have a hyper-globalized in terms of cost. No product is manufactured in one part of the world. It's globally manufactured. Now, global upheavals that you saw during COVID, everybody faced the same kind of scenarios. And then you have the national and local politics. I mean, there was not a national cry saying, I got to take care of my people first before I take care of anybody else. Those type of things. So reducing the capacity or making the capacity inward focused. All those things played out in this case at the same time. However, we all know the future is not bleak. We are looking at it 5 years afterwards. And resiliency was tested and we had a way to come up. However, a mechanism needs to be in place to engineer a sophisticated web of incentives. So nobody has figured that out yet. What should those incentives be? I went back and checked on the national stockpile for US. Guess what? We are still at the same level where the pre-COVID we hit. So if there are COVID with similar intensity hits today, we will unfortunately go through the same type of upheavals. We may do things a little differently to protect ourselves individually. So the incentives have been aligned. Otherwise, divergent interests shares risks and rewards and promotes data transparency. Definitely, data has become available more. Transparency, still a little bit questionable. I'll stop here and say if you guys have anything to contribute towards key takeaways from the part of the world that you all lived through the COVID.
Want to add here in Indian context, like as you said, war-like situation, and Tesla and General Motors was forced to manufacture. In Bharat Electronics Limited, they were particularly producing the tubes which go to some medical devices. We have one SBU, they focus on only tube production. But while the COVID hit, everybody knows, like in India, we had a huge order of 30,000 ventilators. We clean out all our radar system SBUs and missile system SBUs, clean out the floor which we had laid out before, and set out assembly lines for this. And we went through that production. It was completely, like, all the SBUs were shut down. It complete lockdown, but particular persons who were working there, and they had got a specific training, like what was needed at that moment, and they were put into the role there. And in short period of time, like, even the facilities were developed in very short time, so order was increased to 50,000 ventilators. So there was a similar situation here also, like in India.
Fantastic. Anybody else?
When those ventilators, they were not clinically useful.
Right.
A lot of them were just stocked. But on paper, we had 100 ventilators in a hospital. But they did not serve the purpose as required for COVID. So I don't know whether the quality assurance was checked. Even the PSA plants, which is also they were established, but the quality of the minimum oxygen purity was not achieved. So the structures were in place, but it didn't meet the demand.
Anybody else? Anything positive to say? No, I take what you said with. Sure.
Supplier development. I don't understand in Indian setting how do government organizations or hospitals or institutes do this supplier development, because they're always looking at tendering and seeing we get the L1 price based on specifications given. So it is not allowed. It would become seen differently.
I want to add, like, to respond to my friend here. We do have this actually in PSUs. In the policy itself, the public procurement policy, all the PSUs has to mention their procurement plan of coming 5 years, and accordingly they have to develop the local suppliers for that also. Even if a particular PSU, if I name it GAIL, Gas Authority of India Limited, they have this vendor development seminars throughout the countries. We have, like, last year data as per their website, they have organized I think 68-70 webinars, such webinars. They not even help understanding the way like how they can deal with these big giants. They even support financially. They even help in the legal documents framework, what was bare minimum. Even government has like, whenever you are participating for a bid in such level, you have to pay the minimum bid pricing or security deposit. That has been left over for the new suppliers, MSMEs. So in this way, these PSUs are supporting.
To just to answer your question, supplier development is it's a very vast. Uh, it's on one end of the field is developing a supplier to develop their capabilities to develop a new product. That happens in industries where that constant ecosystem has to be there. The new people are coming in and doing it. Then you have established mature supplier base, but you don't want to lose them along the way because of bad management practices of the suppliers or supplier subject to shocks because the buyers are not helping them with the right information sharing and things of that kind. So there's a responsibility on two ends. The end that the buyer plays, the end with the supplier plays. So true supplier development is a combination of things that happen. On paper, I'm sure a lot of supplier development programs have that. To what extent the culture of that particular industry allows it, I think it's very industry based. Some industries are natural, some industries have adversarial kind of relationships. So that's how I would say. I wouldn't blame the supplier development per se. It's the culture of how that is implemented. Okay, let's keep going. So we talked about not everything had gone wrong. So we had some good news that came out under the titles of resilience and innovation. So first, I'm going to introduce to you the uncertainty framework. Then I'm going to talk about the reverse logistics idea called refurbishing and how, similar to what you said with one of the companies here, how a company in the US actually refurbished ventilators and helped. So this is the uncertainty framework that I want to spend some time. You might have seen this. It's a 2x2 matrix. On the top, you have what's called as demand uncertainty. And for our purposes of discussion, we will divide it into two simple ways: low uncertainty, high uncertainty. And we'll kind of label two types of products there. The low uncertainty is your functional products, and the high uncertainty is your innovative products. And we'll talk about that in a second. Now, the other side of the equation is the supply uncertainty. And again, for simplicity, we will label them two ways. Low supply uncertainty, which means you have a very stable supplier that would supply what you want, when you want, at the quantity you want. No surprises there. And then high uncertainty suppliers who are evolving. So from a healthcare perspective, under normal circumstances, I have put some examples there. Your PPEs and gloves and things of that kind, under normal circumstances, is a functional product. If there is no COVID today, hopefully, and you go to hospital systems and say, how do you order? They would say, annually we need X amount of gloves or masks or whatever it is, depending on what we do in our hospital. Maybe today people are extra cautious, so more gloves are being worn. And they would place a one-time order they could place today and get an entire inventory of, because these are not shelf life kind of products, and keep them stored and distribute them. So it's a functional product. Supply under normal conditions are very stable. Manufacture of this is not anything too creative, just stitching things and all, and it is easily available and with a lot of sources, even locally. So you don't have to go internationally to get your gloves and masks and things like that. So supply uncertainty is low, demand uncertainty is low under normal circumstances. And so a PPE should behave in quadrant 1, which means you don't have to every day monitor its inventory. Every day look at how much you want to order. So that's what. And you want to keep the inventory as controlled as possible because you can easily get it. That's the idea there. Now let's move to quadrant 2, where the supply uncertainty is still low, but the demand uncertainty is a little higher because the product behaves more like a fashion type of product or a product with innovation. The ventilator to some extent falls into this category. As you said, as the gentleman said, not only the product has to be produced, it has to be configured to the settings, to the kind of use that you do with that setting, purity of blood and whatnot, and so on and so forth. So it behaves a little bit innovatively depending on the hospital system, and the demand is not stable. You're not going to tell, I need 10 ventilators every day. The ventilator demand goes a little bit up and down. Respiratory kind of diseases, they hit, then it goes a little high. Depending on the type of patients you receive, it may be higher, and so on and so forth. So a little bit of forecasting is needed there, and we put it into quadrant 2. This is again under normal circumstances, a ventilator. So when you have a demand uncertainty slightly high, there inventory is a good word because you need to satisfy that need. So carrying a little bit of extra inventory of these things may not be. Now, who carries them is a different issue. Sometimes they may be carried in a centralized fashion by the government. They are government hospitals. Sometimes they may be carried by distributors as a way of providing service to you. So who carries it, you could work with, but some inventory is needed of them. Now let's move to quadrant 3 under normal circumstances, which is the supply uncertainty is slightly high. The demand uncertainty is not. And example would be here, the diagnostics kind of things. As new technologies come in, these products that are coming in are not available at the same level of other products, like a ventilator versus a diagnostic equipment. We're talking about more MRI machines and things of that kind. Now, you are talking about dialysis machines that would fall into my number 2 category, where demand might be slightly high, but you could make the supply still available because of the way you manufacture it and give it to people. So evolving diagnostics is slightly different because of innovation. People talk about a lot of solar power type of devices. Those are evolving kind of supplies because they are not at the same level of hydro and other kinds of supplies. So what you do normally here are risk hedging. So a hospital or a particular unit might not have this diagnostics. The diagnostics units are centralized. So many hospitals will share. That's why they say, go to these diagnostics centers to do this work. So that's called the risk pooling kind of an approach that people do under that. Now come to the quadrant 4, which is the worst quadrant we want to be. Both uncertainties are high. Very rarely you run into these things. Some new products that are coming in, new processes may fall initially into this category, but rarely we want to be where you want the agility to be the number 1 thing, which means it has to have a combination of all 3 quadrants to put together as part of that supply chain. Now, what happened during COVID was something that is in quadrant 1 and something that is in quadrant 2 started behaving like it's in quadrant 4, the PPE and ventilators. Because of the demand uncertainty being high, supply uncertainty, even if, people manufactured, our gentleman here is saying it's not ready for use, whatever it is, it's not available. So evolving supply kind of a thing happened there. So it fell into quadrant 4, and it's very difficult to turn a ship halfway through, which is what happens to healthcare. Healthcare is like a huge ship in any country. It's going in one direction. During COVID, you had to completely turn it around, and that means you had to have the highest amount of agility, which did not happen. So I just want to present this framework to you. Any supply chain that you look at, the first question you want to ask is, tell me about your demand uncertainty and tell me about your supply uncertainty, and put it into a quadrant here as a starting point of analysis of that supply chain. So pretty simple kind of a tool to use. I think we have learned a few things, right? So we hopefully will do a few things correctly. Testing as an example, we probably will do. I think the most important question to me is, we are all alive and safe and happy. It's the vulnerable population. What have we learned from doing or not doing to people who need more help? That, I think, we have learned a little bit more to be more effective the next time we do. I think the government has woken up in many parts of the world. I told you at Ghana, the Ministry of Health has now changed the policies. So a vaccine need not be administered in remote areas only by a doctor. So now they have, kind of written into their constitution, whatever it is, that the nurses can do certain things, which pre-COVID they were not doing. So those type of developments, so I always call it macro, meso, micro level. Macro is something that happens at the country level. So has the policies changed? I'm sure some of them are. Could it be better? Absolutely. At the meso level is state and local hospital levels and things like that. At the micro, it's the best. The people who delivered this care have learned a lot. They have become very innovative as to how to do it. In hospital systems, I was told the people wore the things to go inside prohibited areas. They came out, they just removed it, wore the other way and went in. They were pretty creative because at that time, getting extra items were difficult. So the innovation that has kicked in as to how to deal with this is something the human spirit will endure. So I think those are some of the things that learn. But what we have also learned because of the uncertainties is how do you track and measure them even better? How do you predict them even better? So that's the other area that we're talking. Are we taking a break or will? Okay. Think about this diagram, take a break, come back, and then we'll continue.